At each level of the spine, we have a different sort of healthy balance between mobility and stability. So in the cervical region, we have the greatest amount of mobility because we need to be able to turn the head in all directions. So we have the greatest amount of mobility in the cervical spine, and that comes along with the least amount of stability and protection of the spinal cord. So not only are the vertebrae the smallest in this region, which also will inherently mean less protection of the spinal cord, but it's also the least stable because the structures need to be able to allow the greatest amount of motion. In the thoracic part of the spine, we have the greatest amount of stability and protection of the spinal cord and the least amount of mobility. So that makes sense if you consider that our ribs all attach to the thoracic spine. So the whole thoracic region of the spine is the spinal portion of our rib cage, or where the thorax is attached to the spine. So it makes sense that we're going to have a limited range of motion there, because we have the ribs in that region encasing all of our thoracic vital organs. So we don't want a large amount of mobility, and the thorax prevents a lot of mobility. So we have the greatest amount of protection there of the spinal cord and the least amount of mobility. Then in the lumbar spine, we have a pretty equal balance between mobility and stability. So we don't need as much mobility as we do in the cervical spine, but we do need to be able to move adequately in the lumbar spine. But we also want there to be a good amount of stability to protect the spinal cord. And also, as we move inferiorly through the levels of the spinal cord, each level has to be able to cope with more and more force than the level above it. So as we get to the bottom of the spine, as we get to the lumbar region, we have the largest vertebrae that need to be able to cope with the greatest amount of forces, because as we move down, the amount of mass that is superior to it, that it has to be able to carry the weight of, increases. Okay, so the curvatures of the spine, every region of the spine has a curvature in the anterior posterior direction or in the sagittal plane. So the cervical and lumbar regions have lordotic curves, so meaning that curvature in the front to back direction. And then the thoracic and sacrum have kyphotic curves, which go in the opposite direction. And then exaggeration of these curves would be lordosis and kyphosis, or hyperlordosis and hyperkyphosis, meaning the same thing. Okay, so there should be a normal healthy kyphotic curve and lordotic curve, and when it's an unhealthy amount, then it's lordosis or kyphosis. So bones of the spine, we have 24 vertebrae in total, plus, of course, the sacrum and coccyx, which sometimes you'll hear the sacrum and coccyx described as being multiple vertebrae fused together. So we have 24 total vertebrae just in the cervical, thoracic, and lumbar regions of the spine, and then the sacrum and coccyx inferior to it. Intervertebral discs. So we have 23 total intervertebral discs. We have 24 total vertebrae, so 23 discs, because we do not have one between the skull and C1, and we do not have one between C1 and C2, but we do have one between L5 and the sacrum. So altogether that adds up to 23. The discs vary in thickness depending on the load-bearing needs of the different regions of the spine. So as I mentioned, as we move inferiorly down the spine, we need to be able to bear more and more load. So there's greater and greater amount of weight that needs to be able to be carried by each segment of the spine as we move lower. So that means that the vertebrae themselves and the intervertebral discs become larger and thicker as we move inferiorly. They act as shock absorbers and contribute to mobility of the spine. So these are cartilaginous joints. They are not synovial. So that means that they can only be amphiarthrotic. They are not diarthrotic. So if you recall, only synovial joints can be diarthrotic. Cartilaginous joint, in this case, it's a symphysis type joint, at best can be amphiarthrotic. So these are amphiarthrotic. They contribute some amount of mobility, but these are not synovial joints. All right, so talking more now about the discs, we have the annulus fibrosus. That's a tough, dense outer layer of an intervertebral disc, composed of multiple layers of fibers crossing from opposite directions to give it strength in multiple directions. Okay, so if you think of the discs as sort of being like a jelly donut, the donut outer portion is the annulus fibrosus, and it's mostly made of collagen. So it's made up of lots and lots of collagen fibers going in all different directions to make it resistant to forces in all of those different directions. Okay, then the jelly on the inside of the jelly donut would be the nucleus pulposus. It's a flexible, semi-gelatinous inner layer that is highly elastic, made of 60 to 70% water, and becomes dehydrated in response to long periods of compression, like normal body weight in an upright position. It rehydrates in a reclining position when compression is eliminated. Okay, so this is a semi-gelatinous substance that is very viscoelastic, like we've talked about before. And most of the tissues in our body are viscoelastic, so they're highly affected by the length of time under load or by the rate of loading, so how fast force is applied. So when we're in an upright posture all day long, that's axial loading, meaning that the weight of the body is coming down through the axiom, through the long axis of the spine. And that axial loading is causing a lot of compression at every intervertebral joint. So it's compressing all of the discs. And part of their function is to absorb that compression stress so that that stress is not going through the bones or affecting the spinal cord. So they're acting as shock absorbers to absorb that stress. But when that's happening over the day, it will start to squeeze out some of the fluid that makes up that jelly inside our jelly donut. So over the course of the day, some of that water gets squeezed out. And so then that's part of why at the very end of the day, when you finally get to lay down or recline in your favorite chair or whatever it is you do, that's why it can feel so good and so relieving, is now you're removing that axial loading, that compressive stress, and allowing the tissue to return back to its original shape because it's elastic. So even though we've deformed it, it will return back to its original shape. So it will rehydrate and the fluid will go back in. That also could be an effect of chronic dehydration. So someone who is not drinking enough water chronically, that is one of many effects it can have on the body, is that we might lose some of the fluid that should be sort of plumping up the discs. And so some water will be lost from that 60 to 70% of water that makes up the nucleus pulposus. And so that can lead to excess forces in the spine, and a lack of ability of those vertebrae or of the discs to be able to cope with those forces. So it could over time lead to disc and other spine degeneration. Okay, the intervertebral joints, as I mentioned, are symphysis type cartilaginous joints, each one formed by an intervertebral disc joining to adjacent vertebrae. Okay, so we have our 24 vertebrae, and we have a disc joining at each level. I mean, of course, except for between C1 and C2, but between all other two neighboring vertebrae, we have a disc adjoining them, and those are the intervertebral joints. The Atlanto-occipital joint is a synovial articulation between C1, which we also call atlas, and the occiput, where C1 supports the weight of the skull. Okay, so if you know your mythology, Atlas had to carry the weight of the world on his shoulders. And so C1, Atlas, is carrying the head, it's carrying the weight of the world. So the primary movement at this joint is flexion and extension, but there's also a little bit of lateral flexion. Now I want to point out that when we do like neck flexion and extension, or that sort of movement with the head. That is, to a small extent, Atlanto-occipital movement, but mostly this is movement of the entire cervical spine at all of its levels. So to just move the Atlanto-occipital joint is a very limited, minor amount of flexion extension compared to the full mobility of the whole cervical spine. The Atlanto-axial joint is the articulation between C1 and C2. Again, C1 is named atlas and C2 is axis, and you could think about it as like the axis of rotation. So C1 or atlas rotates around axis, as in the axis of rotation. So like we see in the picture here, you see that C2 has this little peg that projects upward. That's the dens of C2. And then C1 is sitting on top of it and has this ligament that wraps around the dens. And so then C1 just rotates around the peg that is sticking up from C2. So it's a pivot joint. So primary motion is rotation there, which is true of pivot joints. Okay, facet joints, those are synovial joints, and we have many of them. So it's where the superior facets of a vertebra articulate with the inferior facets of the vertebra superior to it. These are the joints that are most often injured in cases of whiplash, especially where the pain and dysfunction following whiplash continues for a while. Often that's the facet joints that have been injured and are still having a problem later on. So we'll talk about that in the next lecture. So each vertebra has two facets in the superior direction and two facets in the inferior direction. So four altogether. So the two in the inferior direction, or sorry, in the superior direction are articulating with the vertebra above it. And then the two pointing down in the inferior direction are articulating with the vertebra below it. Okay, so each vertebra is participating in four facet joints, two superior and two inferior. Okay, the costovertebral joints are the articulations between each rib and the thoracic spine vertebral bodies. Okay, so we can see in the picture here where you see the rib that's articulating with the vertebral bodies. That is a costovertebral joint. Now you may notice that it's actually articulating at sort of the boundary between the two vertebrae and at the disc. So each costovertebral joint is actually an articulation between the rib and two vertebrae and the disc in between, and that forms one costovertebral joint. So we have 12 pairs of these joints. So we have 24 of these joints total because it's where each rib attaches to the thoracic spine. Then the costotransverse joints are the articulations between the transverse processes and the ribs. Now, this only applies to the first 10 ribs. So this is happening at T1 through 10 with the first 10 ribs. And at our floating ribs, at the 11th and 12th ribs, they do not have this extra articulation. So this is, if we look in our picture, like if you look at the bottom right, the overview here, you can see how the rib goes from the body of the vertebra and then travels posteriorly and articulates there with a transverse process. So the first 10 ribs do that, and those are the costotransverse joints. So we have a total of 20 of those articulations because we have 10 ribs on each side that have that articulation. Okay, then the anterior longitudinal ligament is a thick, long ligament that runs the whole length of the spine, all the way from the occiput, all the way down to the sacrum. So that's what we see in this picture here in the anterior side of these vertebral bodies. So it's running that whole length of the spine. It attaches to the anterior vertebral bodies and to the anterior portion of the intervertebral discs, and it strengthens the anterior spinal column and limits extension. So it's a passive restraint, or we could say an inert restraint, meaning that it doesn't produce force. So it's a passive restraint that limits the amount of mobility into extension. Okay, so if we start going back into hyperextension, we'll be limited by how much flexibility there is in this ligament. So how much movement into hypermobility this ligament allows. The posterior longitudinal ligament, we also can see in this picture here, but it's the smaller, more narrow one on the posterior side of the vertebral bodies. So it runs the whole length of the spine from the occiput to the sacrum, just like the anterior one. It lines the anterior vertebral canal. Okay, so it lines the anterior vertebral canal, but it's attached to the posterior sides of all of the vertebral bodies. So that might help you remember where this one's located. If you can remember, the anterior longitudinal ligament is on the anterior vertebral bodies, and the posterior longitudinal ligament is on the posterior side of the vertebral bodies. So the posterior side of the vertebral bodies is the anterior portion of the vertebral canal. So it primarily limits flexion of the spine, again, as a passive inert restraint, where when we go into flexion of the spine, we'll be limited by the amount of flexibility or mobility that's permitted by that posterior longitudinal ligament. Then we have the supraspinous ligament that we have running the entire length of the spinal cord. It's attaching to each spinous process posteriorly. Okay, so we see in this picture, if you look at more at the thoracic part of the spine in this picture, you can see the supraspinous ligament that's just going between all of the spinous processes as we go up the length of the spine. Then when we get to the cervical portion, you see that this ligament becomes much bigger and broader. So that portion of the supraspinous ligament we call the ligamentum nuchae. So that is a portion of the supraspinous ligament. It isn't its own standalone structure. It is a portion of the same ligament. And so it's, let's see, in the cervical region that limits flexion of the cervical spine. Okay, so the whole supraspinous ligament is limiting flexion of the entire spine, and it's offering more stability and support to the vertebra and holding them all in alignment and in place to some extent. And then when we get to the ligamentum nuchae, it is very much limiting flexion, because remember, we have a great amount of mobility in the cervical spine. So it's important that we have these passive restraints to help anchor and add more stability to the very mobile spine. Okay, onto muscles of the spine. So there are two groups of muscles that are important in the spine: intrinsic and extrinsic muscles. Now, these terms we can use throughout the body. When we talk about intrinsic muscles, we're talking about those that are completely contained within a segment. So, like, we could discuss the intrinsic muscles of the hand. Okay, so the hands have muscles, small muscles that begin and end just within the hand. So those would be intrinsic. Compared to extrinsic muscles would be like the wrist flexors and extensors that are coming all the way from the elbow through the forearm into the hand. So if it begins outside of the segment that we're looking at and enters it into that segment, attaches there, it would be extrinsic. And if it's contained completely within the segment, it would be intrinsic. So when we're looking at the spine, the intrinsic muscles are the ones that are close to the spine and affect the movement of the intervertebral joints, but they're staying in the trunk. They're not going out to the extremities. Compared to extrinsic muscles, would include respiration muscles, but also are muscles of the trunk that are going to the upper and lower extremities. So they're going to contribute to movement of the upper and lower extremities. And then we also count abdominal muscles as extrinsic muscles. Okay, so for intrinsic, we're really talking about these small muscles that are close to the spine. So we've talked a lot about the extrinsic muscles in past lectures. So here we're going to focus primarily on the intrinsic muscles. So the intrinsic muscles are divided into three layers. We have the superficial layer, the intermediate layer, and the deep layer. So in the superficial layer, we include quadratus lumborum. and then the more superficial portions of the erector spinae group, and the more superficial portions of the transversospinal muscles. Then we get to the intermediate layer, and it's basically the rest of the erector spinae group. So here we're talking about iliocostalis, longissimus, and spinalis. Okay, so the rest of the erector spinae group that is at a deeper level than the superficial portions. So every vertebra and rib all the way up and down the spine has multiple erector spinae muscle attachments. Okay, so this is an extensive group of muscles that attach in many different places all the way up and down the entire spine. When the trunk is upright, erector spinae controls the rate of trunk flexion against gravity by contracting eccentrically. Okay, so this is a really critical function of erector spinae. So instead of just allowing gravity to pull us in the forward direction into flexion, erector spinae will contract eccentrically as we're going into flexion. Like if the intention is flexion, we are trying to flex, then erector spinae is contracting eccentrically to control that flexion rather than just allowing gravity to allow us to plunk forward, for lack of a better way to say that. Okay, so deep intrinsic muscles include the transversospinal muscles, so the deeper portions of those muscles. So semispinalis, multifidus, and rotators. So important for dynamic stabilization of spinal segments, especially in the lumbar spine during lifting and rotational movements. Okay, so these little ones, very deep, are really important for helping to maintain the stability of every level of the spine, especially while we're rotating and when we're lifting and putting a lot of load through the trunk. Now, it's been found that multifidi may be hypotonic, so not activating sufficiently, or atrophied in individuals with low back pain. Now, that there isn't a causal relationship that has been demonstrated yet. So we don't know, like, was it some other cause of low back pain that then caused multifidi to atrophy or become hypotonic? Or was it a problem with multifidi that actually led to the back pain? So there is not an established causal relationship there, but it is an interesting finding that has been demonstrated in multiple studies. All right, so I want to talk a little bit more about the mechanics of erector spinae because how we move and what angles we're at, what position we're at, what posture we hold really affects the function of erector spinae, which really affects the health and normal mechanics of the spine and the forces that the spine has to cope with. So lumbar flexion and flattening of the lumbar lordotic curve changes the biomechanics of the erector spinae muscles. Okay, so we mean normal flexion, like doing sit-ups or sitting up out of bed in the morning or any kind of lumbar flexion, but also flattening of the lumbar lordotic curve. So that could just be a postural abnormality. So you might be in an upright position, but have a little bit of posterior pelvic tilt that's allowing the lumbar curve to flatten. So that's what we're talking about. Could be either situation. Erector spinae already have very short moment arms. So if we look at where the axis is, that is right through the center of the spine is where the actual movement is. And if we look at the perpendicular distance between that axis and the angle of pull or the direction of the muscle force of erector spinae, it's a very, very short distance. So they already have short moment arms, even in a normal position. When we are in lumbar flexion or we flatten the lumbar lordotic curve, those moment arms become even shorter. And we know that shorter moment arms means less of an advantage of that muscle. So erector spinae in that situation have to contract to a greater extent to be able to produce more force to overcome the disadvantage that they have because of their shorter moment arms. So they have to activate to a greater extent during lumbar flexion and if we have a flattened lumbar lordotic curve compared to if we had a normal healthy posture or other positions where we're not in lumbar flexion. So this may alter the erector spinae's ability to resist and control flexion and changes the compression and shear forces in the spine. So we know erector spinae must control our lumbar flexion against gravity. So they're contracting eccentrically to control flexion against gravity. Well, the further we go into flexion, the more force erector spinae must produce because the moment arms are getting shorter and shorter. At the same time, because erector spinae are producing a greater amount of force, it's changing the amount of compression and shear forces that are going through the spine. So the greater amount of force erector spinae produces, the more compression is caused, more compression stress or compression force is caused in the lumbar section of the spine, because as erector spinae is shortening, it's pushing the vertebrae tighter together. So it's putting more compression force on the vertebrae. In addition to that, it's doing that while we're in lumbar flexion, it's also changing the angle of the shear forces. So the force that's causing vertebrae to move one on top of another, it's changing the amount and the direction of that shear force, because of the amount of force produced by erector spinae and the angle at which it's being exerted on the spine relative to gravity. So the flip side of that, activities that require hyperextension, so the opposite extreme of range of motion, also require erector spinae to activate to a greater extent, which again causes greater compression forces in the spine. So the more erector spinae contracts, the more compression force we have in the spine. And in the case of hyperextension, it's because of the length tension relationship. So when we're in hyperextension, or this could also mean somebody who has hyperlordosis of the lumbar spine, so they have an exaggerated lordotic curve. Um, so in that case, the sarcomeres are already somewhat shortened in that position. And so to be able to produce enough force, they have to contract or activate to a greater extent to cause further hyperextension because of the length tension relationship. So remember, we want, based on the length tension relationship, we want there to be an optimal amount of overlap between the filaments in a sarcomere. So what we're saying here is that in hyperextension or hyperlordosis, we have too much overlap. It's not optimal, which means we have to have a greater amount of force production and greater amount of activation to cause further hyperextension because we're not in an optimal position. So Mostyn and Bucock suggest avoiding end range of lumbar flexion and hyperextension for individuals with pain in the lumbar spine. So of course, when we are healthy and have no pain or dysfunction, we want to maintain range of motion as much as we can. And of course, strength throughout that range of motion. Flexibility is not the only consideration. We want to maintain stability and strength throughout our range of motion. But here we're saying that in somebody who does have some kind of dysfunction or pain in the lumbar spine, that it would be helpful to avoid full flexion and full hyperextension toward the end range of motion in either direction, because of the changes to the mechanics of erector spinae that we've discussed here. All right, so thank you so much for watching, and I'll see you in the next video.